it's my pleasure to invite Dr. Anita Sethi. She is heading Fortis Gurgaon and also I believe a new setup also. And we all know she is a prolific oculoplastic surgeon doing great job. So we all look forward to hear Dr. Anita Sethi on silicone sling.
Thank you, Mukesh, and thanks for inviting me to be part of this course. So now we'll move on to the silicone sling, wherein we can discuss some of the cases which may not be suitable for the procedures that we've already listened to. So indications for silicone sling are moderate to severe ptosis with a poor LPS action, Marcus gun ptosis, and the material that we're going to be focusing on in this talk is the silicone rod. So there are some cases, like this is a case that came to me with a 60 years old male. After a stroke, he had apraxia of lid opening, downward gaze paresis, poor bells, and just did not like his crutch glasses and very depressed because he just couldn't see. So what kind of a procedure can we do in these cases? Also in the young children with severe amblyogenic ptosis, can we wait, or what is the kind of procedure we should be doing? So this brings us to the indications for the silicone sling. Unilateral or bilateral moderate to severe ptosis, especially in the younger age group to prevent amblyopia. In certain selected cases of neurological ptosis, and mainly so because this is a reversible procedure. And in some of the traumatic ptosis or the residual or the failed ptosis, or resurgeries, as Dr. Grover had mentioned, because in the traumatic cases, the architecture is all it's all spoilt and it's very hard to find your tissue planes. So this is where a silicone sling is very useful. So the silicone rod has two, it's a double armed, it has two needles which are quite sharp, so there is no tissue drag, and there is a sleeve which is very useful for anchoring your knot. So the steps, I'll just show a video, but just briefly, marking and incisions, very, very important. The depth, the silicone sling is, the technique is really the most important part of the surgery. So the depth where you pass it, checking for the contour and lift on the table, and burying the knot. These are the very important steps of this surgery. So this can be done under LA or GA. I'm describing a case of a young four-year-old boy. We can use any technique. I am describing the Pentagon Fox technique. So we can see I use also local infiltrate to prevent the bleeding. So the marking has been done. I've marked 3 incisions on the tarsus. The incision should be up to the tarsal plate, and you should be very sure that you have reached that level. Now this is a double armed sling. You can go, some people go from the top and meet on the other side. There is no perfect way, anybody does whatever is comfortable. But getting the correct plane, so it needs to be in the correct plane, and you have to maintain your plane so that you don't get bunching of the tissue. You bring it out just at the tarsal plate level. And while passing the horizontally, I like to just take a bit of the anterior tarsus, and that just ensures you get a very good lift and contour. In resurgeries, it's a little harder, but in fresh surgeries, the needle goes through very smoothly and very nicely. At this point, when I take it out of the second brow incision, I like to look for my lift and contour at this point, so that if I'm not happy, I can repass it. So here we can see there is a good contour, there is a good lid fold being formed. So we then can close the knot. Now this is the sleeve. We're cutting it in half. In this case, I've passed it vertically, and there we've passed it, and then we tie knots after that. You can tie as many knots as you want, you just don't want it to slip, so at least 2 to 3 knots. And in this case, I actually anchored it to the periosteum. I now don't feel the need to do that. This is the most important step. We have to bury it deep inside the tunnel, and the biggest complication people face of the sling is really extrusion of the knot. So we have to be very, very careful about burying the knot so that there is no extrusion and no infection. So just to highlight the points, so these are the incisions. I always mark the center of the lid, and this case I did with 2 skin incisions, but now I prefer 3 incisions on the lid because I feel it gives me a better contour. I make my incisions around 3 to 4 millimeters from the lid margin. Again, it gives a good lift and a good contour. There are many kinds of slings and many modifications. There's no one technique. So people use 2 incisions, 3 incisions. Some people actually make an incision, a lid crease incision, and do it under direct vision. So there's any way can be. There's no any one good way. All ways are good if it works in your hands. The sleeve, I find that tying the sleeve horizontally is definitely a better way, a more stable, better correction. Here I'm using the needle itself and just passing the needle through the sleeve, and this is also a better way of doing it because otherwise catching the rod takes a lot of time sometimes. So we're passing it horizontally, and then you can just tighten it. You actually don't even need to put knots after that. It stays in place and it's very stable, and you're not having to counter for gravity because it's horizontal. So I find tying the horizontal knot definitely a much better, more stable way. You can also trim the excess lid fold. In many cases you can see there's an excess lid fold which needs to be trimmed. Skin fold. So I'm just at the risk of being repetitive. This I feel is just the most important part. We have to bury the knot. So you should make these a tunnel or a pocket over here. You can make it at the time of incision, or like I'm making it now after passing. Of course, you don't want to cut your sling. So it's very important to have a nice big pocket and actually make the pocket superiorly so that again there's no sink with gravity, which can be the case. And then you make sure that you bury it nicely. So this is it. It has to be buried very, very nicely, and cut these ends small, and I use double layer for closing to be absolutely certain that it doesn't pop out again. So now coming to the neuro cases, I find it a very useful procedure for CPEO, which seems to be more common and patients are coming to us. So firstly, you have to undercorrect the patient because the eye doesn't move, they have a lot of dry eye and exposure chances. And then in the cases where you do need to remove it, this is a silicone band, not a silicone sling. But in the cases where you do need to remove it, it's very easy to remove it. You can just pull it out. Another problem that people feel is that there'll be a lot of lag of thalamus. But there is sufficient elasticity in the silicone sling, and you can see that there is complete eye closure. There's no lag of thalamus at all. Especially in the resurgeries. In resurgeries, anyway, we know lid lag and lag of thalamus is going to be more. So, but even in the resurgeries, you can see at week 1, there's a huge amount of lag of thalamus. But by week 4, that has really decreased. The complications, most importantly, is this extrusion of the knot. Now, this was a patient of CPEO. I replaced the knot twice. It just kept extruding. Maybe she had some skin pathology as well. I then had to actually replace the knot, make a new incision at a deeper plane, and I had to replace the knot on the other side, and then she was okay. Notching, especially in resurgeries, again, one has to be careful and see it on the table. And rarely you get things like slippage, where I used an ETO'd rod long ago. So don't do that, use fresh rods always. So the advantage is that it is adjustable, reversible, good results and easy. The pearls are, the depth of the sling is so very, very important. The lid incisions up to you, but make sure the placement is close to the lid margin for a good lift. The horizontal knot is a better lift, I find. Burying the knot is extremely important, and the excess skin should be trimmed, especially in the severe ptosis, to give a better cosmesis. The perils again are the knot extrusion, the notching, lag of thalamus, so one has to warn the patient, watch the cornea, and be very, very careful. Thank you.
Thank you, Dr. Anita, for a very self-explanatory talk. You have highlighted the important steps, mainly about burying the knot and all. Any comment? Dr. Santosh, she is taking a bite in the tarsus also. Do you follow the same thing?
I don't take a bite in the tarsus, but some advocate it because epitarsal migration is the most common cause for undercorrection. So if you take a bite in the tarsus, then that makes it secure. But you know, as we know, oculoplasty surgeons think mechanically, but it's the scar tissue that determines where the sling is finally going to be. It's nothing to do with the suture. Suture cannot hold the sling there forever. And silicone is something that does not cause silicone scarring, etc. It is something that does not induce scarring. So epitarsal migration is always a problem.
Sometime, like if you are basically needle is not passed absolutely symmetrical in tarsus, then you may even have a notch there while passing
It's
it.
just, as he said, the epitarsal tissue. I'm not actually going into the tarsus.
Okay.
And yeah, I mean, yes. And you assess, you'll know it right on the table, no?
Correct.
The only problem is that if you somehow only the first pass is the best, and if you try to improve that first pass, in my hands, I'll never get it better as good as the first. So, but yes, if you're getting a notch, definitely you will release it there.
Yeah, beauty of the procedure is that it can be reversed on table very easily. Yeah, that's true. And I think one golden rule in any plastic surgery is that on table surgeon satisfaction is of paramount importance. If we are not satisfied on table with our own work, try to redo it there and then only. Sometimes we feel that patient will become all right after 10 days or 7 days. But if appearance is not up to the mark on table, patient will never become normal. So I think better to redo it there.